Hello, we are here at 2016 EACTS meeting in Barcelona, and we are just ready to start a conversation of the role of sutureless valves in conventional aortic valve replacement surgery. I have with me Professor Foliguet from Nantes and Lille, sorry. Nancy. From Nancy, and Professor Conradi from Hamburg.
Hello.
So let's start the discussion. We know that in the past 2-3 years, a lot of scientific publications come out on the role of sutureless. Recently, even 2 consensus papers. One of the role of sutureless valve in cardiac surgery, and even in minimal invasive aortic valve replacement. Thierry, which is your opinion? Which is the real advantage of this kind of prosthesis, and which is the best patient profile and indication for this technology?
So this is a very important question because as Mattia Glauber is pointing, these are new devices and which are finding their role, and we're not sure where they stand. But from the literature and from what we publish, I see 3 main advantages. The number one is that these are very easy and friendly valves to use, which can be obviously placed minimal invasive, and they don't require a very expertise, high degree of training. Number 2, they have effective orifice area which are very low, and since they're stentless valve, they don't have the stent, so they actually have a very good gradient, almost as good as well as a TAVR, but certainly better than the standard valve. And the third thing is, since you have a decrease in operative room time because you have a decrease in perfusion, extracorporeal circulation, you also have a decrease in the ICU and in transfusion, so the patient seems to do better. We are organizing a randomized controlled trial called the PERSIST AVR trial, which will look exactly at this and will compare the role of this valve versus standard bioprosthesis. And we'll have the answer within 2 or 3 years.
This is the biggest study in cardiac surgery with the highest volume of patient enrolled. So a big effort in which we will compare 2 technologies, one with suture and one without. What you will expect from this study?
Personally, I don't expect that there will be lower mortality. I think that the result will be about the same, but what we should find different is in terms of maybe renal failure, because since the operation is quicker, there's less transfusion, maybe the renal patient or the old patient may do better. They should come out quickly of the hospital, and also improve gradient. So this should be the 3 things that we should have in the studies.
We have a higher and continuously increasing of number of TAVI procedure. So these valves can cover the gap between conventional prosthesis and TAVI. Which is your opinion about?
Yeah, it's true. I think they, even by their design intent, they're somehow in between. They're like a hybrid valve, so to speak. I'd say it is a openly surgically insertable valve. That's true. You need extracorporeal circulation, cardiac arrest, but you're speeding up the procedure. It's, as Professor Foliguet has said, it's a rather straightforward, easy implant, flat learning curve. So I think if it's carefully introduced in the clinics, we are going to see a couple of major advantages compared to standard stented xenografts, such as, I think, mostly improved hemodynamics, since it's an expandable type of technology and not a constringent like in a suture-based. So I would expect, especially in the smaller routes, in the small, narrow, confined spaces, I would expect low rates of patient prosthesis mismatch, such as we see frequently in patients that receive stented bioprosthesis of 21 or below. And then the discrimination to TAVR also is the other aspect. And here I would say, from what we know now, with the implants that we know, a commercial, trial, registry, whatnot, the pacemaker rates are somewhere in between stented bioprostheses and TAVR. So that's an advantage also, especially as TAVR is addressing more and more intermediate low-risk patients. That is something of a concern, I think, because how can you implant a 60-year-old with a TAVR maybe in 10 years and tell him you're going to have to live with AV pacing for another 10 years? You cannot just not do that. You know? They're going to develop cardiomyopathy and so forth. So if you have a device that will allow you for a hemodynamically stable implant with expected good durability, we'll have to see if that proves to be true, but the data are promising up to now, then I think it's something that has a very well-defined space in between the two other technologies.
I personally think also that this kind of technology will really improve the number of procedures performed with a minimal invasive approach. Yes. We are in a changing era of cardiac surgery, and there are two ways to stay on the podium treating aortic valve disease. One is to do minimal invasive and to increase the number, and the other one is to have better devices, to have longer follow-up, longer durability, and better outcome. And this combination will surely increase the number of minimal invasive, because we know from the literature and even from our personal experience that minimal invasive has better clinical outcome. The only thing that we can do it only with longer cardiopulmonary bypass time and longer cross-clamping time. True. So sutureless technology can help us to shorten, especially in high risk or very more demanding complex minimal invasive procedure. We can shorten this side effect of conventional prosthesis, making the procedure much more reproducible and increasing the number of patients who can benefit from this. Thierry, you have done a lot of evaluation about health economics with sutureless technology. Can you make a comment on this?
Yes, at this point, as you know, the sutureless or the valves bioprosthesis compared to TAVI is less expensive. This is true in the US, this is true in France, we have the data, and this is true also in other centers like Belgium and Italy, where there was some direct comparison between sutureless and bioprosthesis. Because the patient gets out of the hospital quickly, and because of the reduced cross-clamp time and OR time, you gain some time, so you gain some money. Now the question comparing to TAVR is that the cost of the device is so expensive that it increases the overall cost, and at this point, TAVR is not cost effective. There are some interesting studies to show that if you want it to be as effective economically as bioprosthesis, you have to shorten the length of stay about to 3-4 days maximum. The problem with this is if you get the patient out of the hospital within 3-4 days, you have patients that can develop AV block after this and who will eventually can die because they're not being monitored. That's number one. Number two, in there's the cost of the eventual pacemaker, which is about 25% of patients that are implanted with TAVR, and this is not taken in the overall cost, so that's an extra cost for the hospital to take into account. And the third thing is the cost of, these are old patients, whenever you have a complication, and there are a complication, then it can be very devastating because you have the complication of acute renal failure because you inject a lot of dye. And we see in our unit that sometimes, even though only very few patients have complications, these are catastrophic complications, and they end up sometimes staying very long time in the ICU, and that increases the cost. So these are my conclusion, and this is the conclusion of studies being performed retrospectively and also prospectively at this point.
a very strong aspect in favor of surgery.
Surgery.
Yes, and we have a higher demand from the patient and even from the companies to implant more and more biological prosthesis in younger patients, seeing that the option of a future valve-in-valve procedure is a way to stay away from anticoagulation therapy and mechanical prosthesis. Is it possible with sutureless valve and rapid deployment valves to perform a valve-in-valve after the long duration of these valves?
Well, there's very little experience up to now. I would say that by principle it is possible. We've done occasional cases, single-digit numbers of procedures where it did go well. I'm not saying that is very representative as of yet, because we have to gather more. But the point that you touched on, Mattia, patient perspective, I think is extremely important, because now, as the things are going, patients are confronted with two decisions. One is state-of-the-art analogous sedation, stick in the groin, 30-minute procedure with out of bed, couple of hours post-procedure, versus full sternotomy, arrested heart, stented bioprosthesis with possibly inferior hemodynamics. So I think the only way to keep up the good results, the good aspects of surgical valve implantation, is to decrease the surgical trauma. So I think there is no excuse anymore for isolated aortic valve replacements via full sternotomy, simply because patients are afraid of it. It's very easy for the surgeon to say it's not a big thing, it's well tolerated, but that is our view. The patient's view is very different. And I'm seeing something of a parallel with TAVR versus SAVR as with PCI versus CABG, where maybe the referring physician says you have two options. You can have a TAVR, but you may have to come back 5 years, 10 years because the valve deteriorates, or you can have your chest opened, you can have an arrested heart procedure, and it may be more durable. And I could envision many patients deciding on the first option because they are simply afraid of the initial impact of the procedure, and because the consequences of TAVR, the downside, prospected or anticipated earlier failure, are further away. So psychologically, it's not as present. And as surgeons, I think we have to emphasize the good things that we have proven over the decades: durability, extremely safe procedures, which is, an isolated surgical AVR in an intermediate or low risk patient definitely is. Keep that up and try and incorporate more minimally invasive aspects into the procedure.
I have a last question for you. You are working in a teaching hospital, and you are responsible for younger residents. In your opinion, is it easier to teach a resident implanting a sutured valve or to deploy a sutureless valve, either in full sternotomy or minimal invasive setting?
I think it's a good question. I think a mini sternotomy is very teachable, or a mini thoracotomy, and I don't see a reason why the young surgeon cannot perform it if they know exactly and you show them the limit. So this is not a problem. I think that to implant a sutured valve through a mini sternotomy, already the surgeon should be very proficient with suture technique and debridement. Whereas with the sutureless, it's much easier. So to answer your question, I think it's more easy to teach sutureless and more reproducible and quicker than sutured bioprosthesis.
Yeah, I agree completely.
So we are living in an exciting era of medicine. Technology is evolving. New therapies are continuously coming out. Most of the time we are under evaluation and discussion once we start with new technologies, and even in sutureless valve, obviously we need to wait for a long-term outcome of our patient. But up to now, how many years of follow-up we have now with this?
7 years.
7 years. with
Sutureless Perceval.
and with which kind of outcome? Do we have freedom from?
Freedom from we have survival, freedom from structural valve deterioration, and all the MACE. And we have 95% freedom from structural deterioration at 7 years. With the Intuiti, I am not sure, I think it's up to 5 years.
Yeah.
With also excellent results.
Exactly. Yeah.
So we have in front of us a period in which we do not know if we have a future with suture or without sutures, but this obviously will be one of the next answers in the next few years. Thank you for being here. It was a great pleasure to have
Thank
this
you,
kind
Mattia.
of discussion.
Thank you, Mattia.
Thank you.
Congratulations.
Thanks.